Hello and welcome to Organ India's Facebook Live. Today is 19th April and everyone the world over is observing World Liver Day. April 19th every year is a chance to build awareness and understand how important the liver is for our body and how liver diseases can be effectively managed. According to the WHO, liver disease is the 10th most common cause of death in India and thousands suffering from liver disease annually. Joining us today to mark World Liver Day is Padma Shri, Dr. Arvinder Singh Soin, Group Chairman, Institute of Liver Transplantation and Regenerative Medicine, Medanta The Medicity. He is credited with over 12,000 complex liver, gallbladder, and bile duct surgeries and has performed over 3,500 liver transplants with a 95% success rate. Dr. Soin, welcome to our Facebook Live. Thank you so much for taking the time out and joining us today.
Good to be here with you.
Okay, so Dr. Soin, I mean, the fact that a World Liver Day has to be observed every year means the problem of liver disease is quite bad, the world over and in India. Could you just shed some light on how bad it is worldwide and, of course, in our country?
The World Liver Day was made when hepatitis B and hepatitis C were major scourges. They were major cause of liver disease, liver failure, liver cancer. This was made like close to 25 years ago. And this is obviously to raise awareness of the importance of liver diseases as a cause of, morbidity as well as death. You've just spelled that out. Now, what has happened is that although the number of patients who have liver failure due to hepatitis B or hepatitis C has gone down because we are able to treat those diseases at an earlier stage,
Right.
the two other kinds of diseases which are still on the rise is one is alcoholic liver cirrhosis, which remains a cause of major liver damage and liver cirrhosis and liver cancer in about 25% of the cases,
Okay.
and something called NAFLD, non-alcoholic fatty liver disease. Would you would you even care to think what that means when I tell you that 1 out of 3 adults in India have a fatty liver? That's how
Yes.
common fatty liver disease is.
Wow. Okay.
But of course, not all of them will eventually develop a bad liver, hepatitis, cirrhosis, and so on. But about 10% of these people will develop significant liver damage. And out of these, about 30% of them will either have a cancer or terminal liver disease needing a transplant. So it's pretty serious. And just as well that the World Liver Day continued for a couple of other diseases, but it continued now because the new scourge is non-alcoholic fatty liver disease.
Right. Right. I know a lot of people who have fatty liver, including myself, a few years ago. So I can imagine, like, a lot of people do have it.
Yeah.
Um,
Sure.
So yeah, so then those are the main causes. I mean, yeah, and I wanted to ask you that people who don't have are not alcoholic and have no, hepatitis, whatever, they end up a lot of the time. I've met so many people who have, out of the blue, got liver disease. They never had any problem. They didn't even have fatty liver. They never knew they had it, and suddenly, boom, they're told that sorry, your liver's, really bad, and you're heading towards a transplant. So, what are the red flags? Are there red flags? I know it's difficult to kind of know it instantly, but what are the red flags that you watch out for in terms of how to check if you have a liver disease?
So, Sunana, when you say that people who don't have alcohol, and I'm assuming they don't have hepatitis B or C virus infection, and yet they have a bad liver. We are
Right,
talking about this latest category of very major liver disease, which I just alluded to,
right,
and that's non-alcoholic fatty liver disease. Now, the main causes of non-alcoholic fatty liver disease, or NAFLD as it is referred to, are uncontrolled diabetes, obesity, bad lipids or bad cholesterol, and there is a family tendency towards it. It's not a one-to-one. It's not like if I have NAFLD, my children will have to have it, but it is more commonly seen running in families. It's a lifestyle disease. So when I say lifestyle disease, people who are sedentary, even kids who sit in front of computers, who have junk food. I mean, you don't have to have alcohol or oily, or oily
right,
food even when you're a child. And
Mm.
hardly any parent actually controls or rations the kind of junk food that their child has. So this all starts during childhood. And when they're having junk food, which is full of fried stuff, and they're not moving much, they're more interested in online games and sitting on their devices. That's that's when the seed for NAFLD later in life is sown. And of
Okay.
course, later on, if you have a sedentary job, if you're not exercising, and if you're taking fried food and sweet things all the time, then that's a very fertile soil, so to speak, for fatty liver to happen. So when you say red flags, if somebody's been having uh, lots of fatty food, that means oily food and sweet food, you do not exercise, you're more than 10% of your BMI over your normal BMI, and normal BMI should be in the region of 25, 26. So if your weight is 10% higher than it should be, those are red flags. These people are definitely likely to have fatty liver. If somebody has diabetes for more than 5 years duration, almost certainly they will have a fatty liver. And if somebody's got this running in the family, like two, three, four people in the family who have it, then again, that's a red flag you need to look at.
Okay.
So
So it can be hereditary.
the risk factor, like I said, it's not one-to-one hereditary, but it
Got it.
can run in families. A family may have 4 out of 20, whereas a normal, non-alcoholic fatty liver disease present in a normal family may only be, you know, uh, let's say 1 in 20. I mean, no other liver diseases. So NAFLD may be higher in proportion in families compared to other liver diseases.
Okay.
But it's
Okay.
not like
And
every child of every parent that has NAFLD will get NAFLD. It doesn't work like that.
okay. All right. And when a patient, somebody comes to you and they have a liver, at what time do you, at what point do you realize that, okay, this person is heading towards a transplant and, one should advise him of the same?
So, liver disease actually gives a lot of warning signs in the sense that you may not become sick or ill with it, but if you've had any of these four causes, and I've repeated them already many times, if you have any of these four causes in your life, that means alcohol or obesity, diabetes, bad lipids, family tendency, Hep C or Hep B, then you should definitely be getting tests done every year if you're more than 45, or every 2 years if you're over 30 years of age. So that's one. So that's one way of picking up disease early. The second is that if you actually known to have liver disease, then things can be much worse in the sense that you are about 20 to 25% likely to develop a liver cancer. Liver cancer is very common in patients or people who have liver disease. Liver cancer is one cancer that does not develop suddenly in an organ. It usually develops in a diseased organ. So only when the liver is diseased from one of these reasons will actually someone get a liver cancer. And then once the liver goes bad, then you will feel weak, you'll feel tired, you might lose weight, you may have anemia, which means a hemoglobin of less than 10. And the blood counts in generally start to fall. Like the TLC will fall, the platelet count will fall. And then you may start to retain fluid because liver has more than 500 functions. So one of the functions of the liver is to make sure that the fluid distribution in the body and excretion from the body happens properly. And if the liver is not working, then the fluid gets retained, which it can be retained in the form of swollen legs, swollen feet, swollen face, or water in the tummy, which is called ascites. So water retention happens. And then you can get high bilirubin, which is more than 2.5, and that's called jaundice. Jaundice is nothing but yellowness of eyes, yellowness of urine, and a level of serum bilirubin or blood bilirubin level of more than 2.5. So you may get those um, jaundice, retention of fluid, weakness, tiredness, anemia. Then you can have vomiting and bleeding together. So they can be a blood vomit, or they can be blood in the motion. That's called GI bleeding, gastrointestinal bleeding. So, and in advanced stages, uh, the collection of fluid in the tummy, which is called ascites, does not subside with medicines, and it keeps on collecting regardless because the control of the liver is totally lost. And that's called intractable ascites. So these are the various stages through which the patient progresses. And then finally, you can have something like excessive drowsiness, sleepiness, confusion, pre coma type state, in which the liver is not able to detoxify any of the toxic substances in our body. And this is one of the one of the other functions, one of the other very important functions of the liver, that it's a kind of a factory to
Right.
detoxify everything that we ingest that our body doesn't need or want. So the detoxification doesn't happen if the liver is very bad, and the substances in the blood will reach the brain directly, and they cause what we call hepatic encephalopathy. Hepatic encephalopathy is nothing but the effect of bad liver on the brain. So I've told you right from the beginning where the
Right.
signs are subtle and you pick it up on regular tests, to a moderate stage where you start to retain fluid, to the severe and last stage where you have bleeding and pre-coma and all that, right? So those are the various symptoms, signs, and how the disease progresses. Now, when one has a decompensated liver disease, now what's a decompensated liver disease? So when somebody has a liver disease with which you're managing normal life, that's called compensated liver disease. But if you have any of these five, six complications like bleeding from the GI tract, vomiting or motion, hepatic encephalopathy, that means the effect of the bad liver on the brain, or intractable ascites, putting on water in the tummy which cannot be cured any other way, and bleeding in any other part of the body also, not just from the GI tract, right? And then the clotting is prolonged, the platelets are low. So these are all forms of decompensation, which simply means this is a medical term, decompensation, but basically means bad complications of liver disease. So when one has one or more bad complications of liver disease, that's the time to think of a transplant. But much before that, if somebody has an inkling of having liver disease, even of milder variety, they would do well to be in touch with a liver expert from before. You don't really need to let their liver disease progress
Right.
far or to
Mm.
the extreme stage before you consult a liver doctor. The other thing that can happen with advanced cirrhosis is a cancer. I already told you that 25% of these patients who have a very bad liver or an advanced cirrhosis will develop liver cancer. And cancer, unfortunately, in the liver is very silent in terms of producing symptoms from the cancer itself. But it may produce symptoms, the symptoms and signs of liver disease itself, they will be present, but there's no specific symptom of the cancer until it becomes very advanced. So patients with early liver disease must connect with a liver doctor and have regular tests, like I said, every 6 months. And if you have very advanced disease, every month or 3 months, so that if and when a cancer develops, it's picked up early.
Okay. And when you people, when we talk to them and when we, go and do our awareness sessions, all of that, they're very apprehensive about a transplant, liver transplant, any transplant rather. What is the success rate like in a liver? And can you please shed some light on the statistics of how successful it is? Because kidney is different because you if it doesn't take, then you go back to dialysis or you have some options, but in liver you don't have that option, so
So, Sunana,
people
that's
are.
absolutely correct. That's absolutely correct. There is a alternative to transplant in kidney failure, but no such alternative exists in liver failure. In liver failure, the only shot you have at living or saving one's life is a liver transplant. Now, I and my team have done close to 3,500 liver transplants in India for the last 22 years since I first started it. In fact, I remember the date when I first did the first case, and that was 5th, 6th of November. We started on 5th evening. So 5th and 6th of November, 1998. That was an adult who was 43 years old.
Right.
Um, I'll tell you a little story about him. So he was 43 years old. He had alcoholic cirrhosis, actually.
Okay.
And we got a cadaver organ, which means a person became brain dead in the hospital, in our same hospital, and we were able to retrieve the liver and transplant him, and he was discharged in 12, 13 days. He lived for 13 years.
Wow,
After
wonderful.
8 years, no, he would have lived until today. But after
Right.
8 years, he went back to alcohol. So in the
Oh,
subsequent 5 years, his liver failed again, and then he died. That was the first successful case that the country saw. The second one was a small child, 20-month-old baby, who had
yes.
something called biliary atresia, and his name was Sanjay and is Sanjay. And we transplanted him just 10 days later on the 15th of November, 1998. And his dad donated 20% of his liver, left side of the liver, for his transplant. He, in fact, while the first patient had an uneventful recovery and was discharged in about 12 days, Sanjay had to spend 2.5 months in the hospital. But eventually
Wow.
he got discharged. And now today he's a doctor. He's
Yes,
24 years old.
I heard that.
Yes.
Yes. Yeah,
Yes. So
that's
he's a
wonderful.
doctor. And we've actually, after that, we've had many children. We've had 4 or 5 children who've become doctors. So, of course, we transplanted them, somebody at 3 years of age, somebody at 10
Wow.
years of age, or that kind of thing. So anyway, so 3,500 cases, and we've now reached a success rate of 95, 96% overall. But in children, we are close to 97%.
Okay.
So
All right.
pediatric liver transplantation is even more successful than adult liver transplantation, just by about 2-3%.
Okay.
Um,
Wonderful.
and this is the record for the patients. And of course, donors, we always say, are completely safe, but then completely safe means 99.9% safety, because 0.1% is the kind of risk that you and I face when we are walking the road or driving a
Right.
car or anything like that. Yeah. So, so if there is a live donor counseling going on, we always tell them that that's the risk, but but all of them do well, basically.
Okay.
But
Wonderful.
I'll spell out the procedures in detail later if you wish.
Okay. So most of the transplants, what I wanted to ask you was from living donors in India. Sadly, rate of deceased donation is quite less. Um, is the living, what people really want to know is that there's this people feel that living transplant will be more successful than a cadaver transplant. So if they get a liver from a living donor, it will be much more successful than it would be if they got it from a deceased donor. Is that accurate?
So what you're saying is that the feeling is that the live donor transplant is more
Right,
successful?
right.
Yeah, that's absolutely true.
Okay,
Um, so I tell you what, um, why is that so? So first of all, let me tell you what's the proportion of live donor to cadaver transplants in India. The In India, about 75% of the transplants are done live, using a live donor liver, and about 25% with a cadaver transplant. And that was the situation in 2019. After that, COVID changed everything,
right,
right? So typically, about 6,000 people would go on the national waiting list for a cadaver transplant every year, but only about 500 people would manage liver
right.
transplants through that route. And you can imagine that's less than 10%. And majority of the rest of them would die on the waiting list, and some of them would switch to a live donor transplant. So then some of them are still waiting. So that's how a cadaver transplant needs to pick up in India, and this scenario is not very encouraging. So it does happen, but not very commonly. But live donor transplant happens much more often. Now, I'll tell you why a live donor transplant is slightly more successful than a cadaver transplant. That's because a living donor is tested in detail, right?
Right.
He or she is a young person, 18 to 55 years old, and they are subjected to very detailed testing. And even if there is a 1%, uh, risk that is attached to a donor operation that we find out upon investigation, we refuse that donor. You know, excuse me. So, um, so the living donor liver is perfect in every way because it's been investigated, and we remove it in the next operating room and just put it in in operating room 2 and put it in operating room 1. So there is hardly any waiting time between. So the organ is excellent, the donor is young, the waiting period between removal and transplantation is very little. Whereas in a cadaver donor situation, especially in India, the donor may be 75 years old. They died, right? So they had a brain death, and these organs are typically retrieved after brain death. So brain death means that they've been in ICU, maybe for 3, 4, 5, 7 days. They had low blood pressure before they died. They had some infection before they died. They had some maybe diabetes, long-standing diabetes. So these things are ruled out in living donors. Living donors never have any of these problems, right? So their organs are perfect, and the cadaver organs are not that perfect. Also, there may be an organ in a small town, and that person, a brain dead person, is transported to a bigger center, and there may be some loss of vitality and viability of the organ during transfer. You know, so there are all these reasons why a cadaver transplant is slightly less successful than a live donor transplant in the Indian context, in the Indian setting, where it is not very well developed. But in the Western world, the results are the same. Having said that, long-term results in living donor liver transplantation, even from the Western series who do both, slight superiority for living donor liver transplants.
Okay. All
So
right.
it's
That's
not just
mhm.
India. Yeah.
All right. Okay. In terms of, so if you have a living donor, that's great. You have a good living donor, you can get a transplant. If you don't, then you put yourself on a waiting list in one of the hospitals, such as yours. What are the waiting lists like, and how long does it take typically for a cadaver donation to happen? So
Okay.
if I put my name on, your list today, uh, by when am I looking at? Is there even a time frame, or you can't say?
God forbid. No. So the thing is that if somebody goes on the waiting list today, the allocation of the organ and the time taken depends on the blood group. For AB blood group, it can take pretty long, especially if you're number 2 or 3 on the list, because it's a rare blood group,
Mm.
and so it could typically take a year or more. In O group, it could take 8 to 12 months. In A or B group, it could take maybe 6 to 8 months. So at least 6 months, depending on the group, and perhaps up to 12 months. And for some patients, that is not practical at all. They can't wait that long. You know, there are patients who are stable who can, but there are others who are not so stable to wait for 6 months because something, life threatening will happen to them during that time. Whereas the live donor situation is like this. Uh, Sorry, another word about cadaver donation. So the procedure is simple. You go to a recognized transplant center. They do a detailed evaluation of the patient. And then after that, we put them on the NOTO website. NOTO is the National Organ and Tissue Transplantation Organization. They have a website where you register each and every recipient. And after registering the recipient, anytime there is an organ within your hospital or in your region or across or in your city or across cities, you are given the priority depending on a lot of predefined factors. Okay, so that's how it works, and I've already told you how long it takes.
Right.
Now
Mhm.
let's come to living donation. Who can be a live donor for liver transplantation? It has to be a family member, and that includes a spouse. It could also include first and second degree relatives. So a cousin can donate, a sister-in-law can donate, a nephew can donate, you know, even a grandson, grandfather. So family member, 18 to 55 years old, not overweight, and certainly BMI less than 28, and blood group matching. Now, blood group matching means if the recipient blood group is B, then they have to have a donor B or O. If it's A, then they have to have A or O. If the blood group is O, then it can only be O.
Mm.
And if the blood group is AB, then it's a universal recipient. So any person, I mean, any blood group person can donate. So that's the blood group rule for live donation. However, we have now instituted two innovations, and they have originated in our team and in India. One is called swap transplantation.
Right, right.
Swap transplant means that if the live donor that's available in the family is of the opposite blood group, that means if I'm A and my brother is B, the another family may have the opposite problem where their patient is B and the donor is A. Then we are authorized as transplant teams and centers to swap the organs between the two families. It's a legally allowed procedure. It's equally successful. It doesn't cost anything extra. It's just that bigger centers like ours can actually maintain such databases and match
Right.
up pairs.
Yeah. Yeah. That was the question, at least somebody had asked whether swap transplants are happening for liver. So, do
Yes.
you maintain a registry? Is it just with
Yes.
your hospital, your group? Okay, so
Yes.
if anybody wants to have a swap liver transplant or even comes to us with a query, we can direct them to your
Meda-
team.
yes, of
Medanta.
course, Medanta is the place, of course.
All right. All right.
The other thing I wanted to tell you in context, if somebody has O group, like I have O group, and my donor has B group, now there can't be an easy swap situation here because swap situation will demand that I will get a O from someone, but I won't get because O can donate to their own recipient.
Oh, yeah.
O is a
Yeah.
universal donor.
Yeah.
So I will not get a O liver in exchange for my B liver easily
Mm.
because exchange is when both parties need it.
Yes. Yes.
The family
The other
that
party
has O
wants it.
group, yeah, does not need to exchange, right?
Oh gosh. Yeah.
So,
Never thought of that.
so that's the situation in which we sometimes do ABO incompatible transplants. So that means I'm O group, my brother's B group. So the B group can be transplanted into an O group person. So it's the wrong blood group. But then what we
Right.
do is we specially prepare the recipient for a month. We take out the antibodies that would normally attack the other blood group, the B group,
Correct. Yeah.
by a procedure called plasma exchange. And we also give medicines which will suppress the production of future such antibodies. So all that treatment needs 3 to 4 weeks. And after that, we are able to do this ABO incompatible liver transplant with 90 to 92% success, slightly lower, 3 to 4% lower than regular group matched
Okay.
transplants.
So again, this is only for living, definitely not for deceased donation.
This is only for living because it needs 3 to 4 weeks of
For
preparation.
weeks. All right.
So people have done it for cadaver transplants also, but it's not that successful in cadaver transplants because it's all a cadaver transplant is always an emergency transplant. You only have like 6 to 12 hours, 18 hours maximum. So you can't really prepare the patient for this kind of a transplant in 12 to 18 hours.
Right. Okay, great. So has COVID reduced the number of transplants taking place? I'm sure it had a big impact initially. But what about now? Are things back to the way they were? Are people still going ahead?
So up until February, March last year, it was fine. Then from
Hmm.
April onwards until September, it dipped a little and then picked up to about 70% level. And now in March and February, well, Jan, Feb, March, it had picked up to normal pre-COVID levels. In fact, we were busier because there were a lot of patients who were putting off their transplants during COVID and they surfaced.
Right.
They said, okay, now we're going to come and have a transplant. But I have been telling them uh, that it's intuitive to sit at home with liver disease, but it's a bad idea because what you're doing is you have an organ failure. And remember, one of the comorbidities mentioned by the government and by the scientists that affects results is the presence of chronic liver disease or chronic kidney disease or even heart disease, lung disease.
Right. Right.
Sorry, it
Yeah.
went off.
So yeah. Yeah. So I just
So,
wanted to
so
ask.
what I'm trying to say, Sunaina, is that I just wanted to relate this with COVID. Now, if somebody has liver disease, which is mild to moderate, there are three levels of cirrhosis, A, B, C. If somebody has A, if they get COVID, they'll move to B. If they have B, they will move to C. And if they have C, then they have 30% chance of dying from COVID. So, COVID affecting liver disease patients is bad outcome. Therefore, if somebody has reached the stage of transplantation in the COVID pandemic, especially because it's going to stretch over years, God knows it might be around for another year, 18 months, not a good idea to wait. It should They should definitely go ahead with transplant because once the transplant is done, they are no longer in organ failure. That's what I
Right.
have been trying to tell everyone. And now they have taken it on board and more people are coming. So we haven't had a drop in numbers so far, except for travel restrictions in the last 10 days. Otherwise, we've had the same numbers this year compared to 2019. In fact, a bit higher.
Okay. Wow. All right. And I mean, I know initially there was this question, should the transplant patients be taking a vaccine, the COVID vaccine? And if yes, then which one? I know you have been advocating the taking of vaccine a lot. So is it a good idea for them to take it? Because a lot of confusion was there initially. I think now mostly people are taking it.
So yes, my patients were one of the first ones in the world to actually take vaccines, and that's because a bunch of them were in the US, some of them were in Dubai, and as you know, the vaccine started in those countries much before they started in India,
Right.
and so a few of them had their first vaccine there, and then. But after that, like I told you, we have close to 3,000 plus patients who are on follow-up. Of course, not all of them are above 45, and this rule for uh, comorbidities and transplant patients has only been for more than 45 until an hour ago. I think the government's
Right.
just announced
Yeah, they've
that
allowed it.
they've
Right.
opened out vaccination for everyone, but it wasn't the case a couple of hours ago. So yeah, so we have close to 1,000 plus patients who have already had one or two doses of vaccine.
Does it
So
matter which
transplant
vaccine they take?
patients, no, it does not matter. Covaxin and Covishield both have equally good results. More important is that they're both safe and they're good with antibody production. But the transplant patients must understand that because they're on immunosuppressants, the production of antibodies which are protective in transplant patients may not be as high as normal people. But there is no disadvantage
Okay.
or adverse effect. So they are safe. But their effectiveness can be lowered by the fact that they're on immunosuppressive medicines. And similarly, patients who have liver disease must have the vaccine as well, both doses.
Okay. I think the one thing you mentioned that patients should come forward. I think that's great. I think what people kind of a little afraid initially, at least, was that because there were so many COVID patients going to all the centers, especially where the transplants were happening, they were very scared of picking up the disease there. I think that was what was actually stopping a lot of people from coming forward and going to hospitals,
I mean,
possibly even now.
you're right because especially
Mm.
people who are over 60, they've been very circumspect. They've been very careful. Even for our parents, I mean, of course, they're much older. Like we have all been careful in taking them to hospitals, and we don't usually do that unless absolutely essential. So yeah, there is an element of fear. But in terms of being the best thing for patients who have chronic liver disease, especially advanced disease, obviously a transplant is better than just waiting around.
Right.
Because one, they will have complications of serious liver disease, and two, if God forbid they should get COVID, then they're in deep trouble.
Right. Okay. Yes, I think that's pretty much. I think we've covered everything. Thank you so much for all your time and taking so much time out. I hope you're feeling well now. I believe I saw on your Twitter feed that you were diagnosed with COVID one more time, but um, it's a very mild strain.
Yeah, so I've had two vaccine doses, the last one having been taken about a month ago. And now I've tested positive again, but it's pretty mild. I mean, I just have some mild sore throat, nothing else. So hopefully it'll be behind me soon.
Very good. Okay.
So
Take
the
care.
positive
Uh,
message from
uh,
here is, of course, touch wood and fingers crossed and everything, that vaccines prevent severe
they
disease and
work.
death. So,
Right.
so,
So
so
they do work.
please do take the vaccination.
All right. Okay. Thank you so much for taking your time out and
Thank you,
joining
Sunaina.
us for so long. And
Yes.
in case people do want to get in touch with you, is there somewhere that they can email or
I
call?
will, yeah, sure. So you can note down one number. I'll just say it out because you haven't written it.
Right. Right.
Uh, 8800 276 222. 8800 276
276
222.
triple two. All right.
That's our coordinator. He can connect you with me via an appointment or explain the whole system, how it works for transplants or general liver disease consults. That's possible. And then email ID is simple. A for Apple, B for boy, ABSOIN at gmail.com. Why I give my
Okay.
Gmail ID is because it can have heavier files compared to the official
Right.
ID,
Right. They
which
can
is
send you some.
arvinder.soin at medanta.org.
All right. Okay. Thank you so much, Dr. Soin, and I hope you get
Okay.
well very, very soon. Thank
Good
you
to
so
be on
much.
the show. I'm quite okay. Thank you very much. Bye bye.
Wonderful. Okay, bye bye.